Hello everyone. Today I am starting with instruments for total laparoscopic hysterectomy. These are instruments for laparoscopic surgeries in general, but a few of them are specific for hysterectomies. We are continuing this series of hysterectomies. The steps of surgery is same as that of abdominal hysterectomy because our approach is abdominal only. But we have not put a big incision on the abdomen, rather we have made primary and secondary ports. What does that mean? That means that this is the abdomen. In abdominal hysterectomy mostly we were taking this incision, right? But in laparoscopic hysterectomies we generally put a camera port over here and 3 secondary ports to support. These are small ports. These are 5 mm ports. This is 10 mm ports. Generally this is a normal sequence. So there is no big incision. The instruments will enter from these ports and then we will perform the surgery. But as we are going from an abdominal approach, we will approach the uterus from upwards down only. That means first your cornual structures, then your uterine arteries, then your uterosacral McEnroe's ligaments. So the approach is that of the abdominal, but the instruments are very different. First one, what happens before proceeding for laparoscopic hysterectomy? We need to catch hold of the uterus so that we can manipulate it. We can change the direction to help the surgeon. So we visualize the cervix with the help of a Sims speculum and then catch hold of the anterior lip with the help of the valsellum. This instrument is called as valsellum forceps. It is a curved instrument generally to fit the normal physiological curve of the vagina and the uterus with teeth at the end. This instrument is having teeth at the end to grasp the cervix firmly. So it grips the cervical lips. It is used in many procedures. Wherever you want to catch hold of the uterus, whether in OPD, any OPD procedure, like you want to insert IUCD or you want to take any biopsy, or in cases of vaginal hysterectomies or hair. So this valsellum is a very commonly used gynecological instrument. It has called long curved shanks with 3 to 4 teeth at the end. This way you operate. See, there are 3 catches as I told in my first lecture of instrument, and then the curved shank. This way it has got a curved shank. We open it and there are teeth at the end, right? Now uterine manipulators. What does that mean? First of all, I want to show you this picture. This is a picture showing how do we perform a total laparoscopic hysterectomy. So there is something called as manipulator which is inserted from the vagina. Part of it goes inside the uterus to stabilize the uterus so that we can move the uterus, and this is the central camera port showing the structures, and this is our operating instrument, mostly the shearer or the harmonic scalpel, which will cut on the tissues inside. So how do we know how to insert this manipulator and what are the types of this manipulator? 2 or 3 types of manipulator are available in the market. Some are the roomy manipulator and one is the Mangeshkar type of manipulator. Here what do we have? We have a central rod and there are screws over here with which we can open or close these teeth which hold the cervix. This is a cup which is according to the size of the cervix, and these are the bars which go inside. They get fixed over here and they go inside the uterus. All of them are available in different sizes because each and every patient is different. The uterine size is different, the direction of the uterus is different. Sorry, the cervical diameter is different. So you have to see first what uterus you are operating upon and check the size of the uterus, and accordingly you decide which bar you are using. Fix the bar over here and then you proceed the cup. This cup fixes inside the this way. This cup fixes here in the portio vaginalis. So the uterus is stabilized, and when you cut open the vault, the cup supports you while you open the vault during the last of your procedure. So it stabilizes the uterus during total laparoscopic hysterectomies, and it also prevents the leakage of the pneumoperitoneum. You can see there is a disc over here. So whenever you are cutting open the vaginal vault, the pneumoperitoneum, the gas starts leaking from the vagina, so you can push this disc and prevent that leakage. Different size cups and manipulators are available. According to the patient, you adjust the thing on the table. This is the way we adjust things. See, this is the handle and the cup. We insert it inside this central thing. Different size manipulators. We fix it by the screwing action, and now this is ready to get inserted inside the uterus. We will hold the cervix with the help of these teeth. See, we can open it. Once we are inside the uterus, we can close it over the cervix. And then we push this up to the portio vaginalis. So now I hope you understand that the tip which was having different sizes, it goes inside and the cup fixes over here. Now the vaginal end job is done. Now we have to create a pneumoperitoneum. Pneumoperitoneum, we insufflate the abdomen with carbon dioxide so that we have a better vision. So how to do that safely? We have got something called as a Veress needle. What is Veress needle? This is Veress needle. We hold it in a pen holding fashion like this, never like this. So hold it in a pen holding fashion so that you are not injuring anything inside with inadvertent pressure. Enter inside the abdomen. It helps in safely creating the pneumoperitoneum. Why safe? You can see that there is an outer cannula which has a bevel tip. It is a sharp tip so that you cut the tissue precisely, but inside it there is an inner sheath. The outer cannula has a beveled needle point for cutting through the tissues of the anterior abdominal wall when you are entering inside. But the inner stylet is a spring. It has got a spring and it is blunt. So whenever you touch a viscera inside, the spring takes the action back and there is no injury to the viscera. It's placed within the outer cannula. The inner one has a dull tip to prevent injury to the viscera. So for creating a pneumoperitoneum initially, having an entry with a Veress needle is safer than having a direct entry. Now this is it works like. We can open it. Every laparoscopic instrument can be opened for better cleaning. There the tip is beveled, the inside tip is dull. This way we assemble the instrument and see the spring action inside, right? Now the trocars and the cannula. Once we have created the pneumoperitoneum, that means the abdomen is already full. We keep a pressure high up to 20 mm of Hg, 18 to 20 mm minimum to insert your primary port. Some surgeons prefer higher pressures also. So these are the trocars. What does that mean? Trocar and cannula. The trocar and cannula, this is the inner one and the outer one. We push it inside. This is a 10 mm size, 5 mm size, right? So it is available in different sizes, 5, 5.5, 7, 10, 12 according to the instruments that you are using. Mostly the primary port that we are having in larger surgeries like longer surgeries where we need precision, it is 10 mm for a 10 mm scope to enter inside. But you can very well use 5 mm scope also. And the secondary ports mostly in gynae surgeries are 5 mm or 5.5 mm because most of the energy sources that we are using, they fit well through these ports. They can be disposable and reusable. These are the reusable one, autoclavable one. But there are disposable also available in the market. You use it once and then throw it away. These are the structures of trocar and cannula. This is a gas vent from where the gas source is attached, from where you insufflate the carbon dioxide. It has the same principle, a pointed inner trocar and outer sheath. This is very, very sharp. So once you have created a pneumoperitoneum, you enter with this pointed inner trocar and because there is already in the pneumoperitoneum inside, so the chances of injury are very, very less. And once you are inside, you withdraw this trocar and only the outer sheath remains. Outer sheath is just a conduit for your instruments and for your scopes to pass inside the abdomen. And this is the hub, and mostly there is a washer over here. Why a washer? Because it prevents the leakage of the gas from inside. See, this is how a trocar and cannula set looks. This is a trocar what we are withdrawing. There is a gas vent from where gas goes, and there is a valve and a washer. The grey colored thing is a washer. Now, most favorite examination questions for PG students as well as UG students, that whenever you are placing a Veress needle, or some of the surgeons prefer direct entry into the abdomen, how do you check that you are at the right location before insufflating the carbon dioxide inside? Sometimes what happens, in some cases you are not able to reach the intraperitoneal structure and you insufflate the gas in the extraperitoneal or some other places, creating false passages. To prevent that, how do you check the intraperitoneal placement of either the Veress or your this thing? Double click. First of all, when you are piercing the anterior abdominal wall, skin on skin, you keep an incision with the help of your blade and Bart Parker knife handle, right? Scalpel. So the skin is already cut. So when you are putting your Veress needle in a pen holding fashion, the first thing that you will go through is your rectus sheath, and the second thing will be the peritoneum. So it will give you a double click sound. Click, click. Sheath and the peritoneum. So while entering, the surgeon knows that the sheath is gone, now the peritoneum is gone. So first test is double click. Then comes aspiration. What does that mean? Take a syringe, attach it to your Veress needle and try and aspirate thing. If you are inside some viscera or you have created some injury, some other material may come out. But if it is in the right location, there is generally a negative suction intraperitoneally, so you will not get anything in your aspiration test. Next one, very favorite, hanging drop test. What does that mean? This is your Veress needle which you have placed on inside the abdomen. Now you attach a syringe over here with some saline. One thing is that, or at the tip of the Veress needle you put a drop of saline. The drop of saline will be sucked inside because of the negative pressure of the abdomen. So hanging drop, you put a drop over the tip of your Veress needle, and if it gets sucked inside, that means you are intraperitoneal. And the last one and the most confident way you can say that you are intraperitoneal is you just attach your thing to your instruments of the insufflator, and it will show a pressure of less than 10 mm of Hg. That means a very, very low pressure area. Remember, intraperitoneal area is a negative pressure area, low pressure area. So if it shows a pressure of less than 10 mm Hg, then you can easily, relaxedly insufflate it with carbon dioxide. Now laparoscopic needle holders. Now I am proceeding. Now entry is done. Now it's upon us how to proceed with the surgery. So first of all, I am taking the instrument. What is the needle holder? It has got a catch over here and a tip. There are many types of needle holders available, straight needle holders, or you have the handle is like this. According to your need, you can select the needle holder. See, other type of needle holders. Whenever you are identifying any laparoscopic instruments on your examination table, just look at the tip of the instrument. See, this tip is got serrations. Some have got grooves so that the needle fits inside. The instruments are just like our open surgeries, open needle holders, but because of the structure, they look a bit different. But for identification, the tip is very, very important. This is your needle holder. There are buttons by which you can close it, you can open it, right? When you close it, the tip opens, and when it is open, the tip opens. Now, harmonic scalpel. What is harmonic scalpel? There are many energy sources that we are using during our surgery. Some surgeons prefer to take sutures on the uterine arteries, but all the other ligaments are cut with the help of energy sources. Energy sources can be your bipolar sources or they can be ultrasonic energy. Here we are using the ultrasonic energy. What does that ultrasonic energy do? It just lyses the hydrogen bonds inside the proteins get denatured and there is separation of the tissue. So this is a harmonic scalpel. We attach it to the machine. It uses the ultrasonic energy and this is the tip by which we grasp the tissue and cut the tissue. Now other instruments. All the instruments mostly look alike. I have already told that what you have to do is you just look at the tip of the instrument. This is a monopolar hook. It looks like this. It's just a hook. Monopolar hook means it is a hooked structure by which monopolar current is passing, by which you can cut open. It is helpful in dissection. Laparoscopic scissors. It is just like simple scissors. Maryland. This terminology is new. A thing which looks like an artery forceps, hemostatic forceps, which can be curved, which can be straight, which have a very precise, accurate tip and no cutting edges. It is called as a Maryland. It helps in holding tissues. You can hold tissues, you can do dissection. Whatever procedures you can do with an artery forceps, you can do it with Maryland. Babcock forceps. Typical Babcock forceps like this. It is an atraumatic forceps. The forceps are like this. There is space between both the jaws so that you can hold soft structures, tubular structures without damaging it. Like you are doing some diagnostic histolaparoscopy, you want to catch hold of the fallopian tube without disturbing it, just hold it with the help of Babcock forceps. And then suction irrigation device. This is a beautiful device, suction irrigation. It has got both the channels, right? You attach your suction machine to one of the channels, and irrigation means attachment of the normal saline, because you cannot mop inside. If you want to check for bleeding or clean something, you don't have a mop in your hand. What you do? You do irrigation, put saline on the tissues and then do suction. Then you suck out that saline what you have put and now you observe the things. So this is a suction irrigation device. Now we will be seeing instruments one by one. This is your monopolar hook. Behind it we attach a cautery and this is the tip. See, this way we can open the instrument. This is scissors. The tip is classical scissors and we can rotate it the way we want to rotate it. This is your Maryland, just like your artery forceps. The tip is very, very clearly visible, right? This is your Babcock. Suction irrigation. If you push it, it is suction, it is irrigation. Both of them done with the single instrument. Now laparoscopic shearer. This uses a bipolar energy. You have to see that this is the tip of the instrument and behind you attach your energy wires. It can catch hold of the tissue loosely if you hold it loosely. If you put it tight, it will cut the tissue. So it is shearer. Shearer means it can do the coagulation and cutting at the same time, and it is very commonly used nowadays to perform laparoscopic hysterectomies. It causes sealing and dissection at the same time. It only depends on which mode you are using, the pressure you are applying. Broad ligaments, round ligaments, IP ligaments. As I told, some surgeons prefer to tie uterine arteries, but you can do the complete procedure with the help of this instrument. Energy sources are enough to do your laparoscopic hysterectomies. So anything that you are cutting, you can do it with the help of a shearer. See how it works. Right? You can close it completely, you can open it, you can do dissection the way you want. This is another look of a Maryland. So how do you differentiate between a shearer and a Maryland? A shearer has a bit of space between it so that you can have the tissue between it, but Maryland does not have one. See, have another look. Shearer has a space, this, but Maryland does not. This way you can differentiate on table. Now again a closer look at the scissors and the Babcock. See the tip, cutting scissors, Babcock, there is a space inside to hold the tubular structure, so a tubular space inside. I have kept a video, typical video of entry inside the abdomen, that how do we enter inside the abdomen while performing a gynecological surgery. We have adjusted the camera outside. This is a simple gauze piece. After doing the white balance and checking your configurations, we enter inside the abdomen by a 10 mm central primary port. This is your 10 mm port, right? We are entering inside. You will see that we are opening the valve and then going inside. This is the urinary bladder, what you can see, and now from down below someone is manipulating the uterus, so you can see the uterus over here very clearly. This is a panoramic view of the pelvis in a gynecological surgery. And now we are about to insert our secondary port. So before inserting your secondary port, you have to check that whether there is any blood vessel in the way. You don't want to actually injure any other blood vessel. The most common blood vessel which we injure during secondary port insertion is your inferior epigastric artery. So beware of that. Check for things, and under direct vision we will be inserting our secondary port, which is a 5 mm port in this case. See, under direct vision we are taking an entry. So your 5 mm port is inside. Now this is your POD. POD, uterosacral ligaments, the ovary, ovarian ligament, right? This is the fallopian tube with the fimbrial end, very beautifully seen. And the round ligament going over there towards the deep inguinal ring. So this way we identify the structure and we proceed with the hysterectomy starting from this place. The ends are the same, like cornua, uterine and the uterosacral, but this way we identify. With this I finish off the lecture of the laparoscopic instruments. Thank you.